All right, so this presentation is being recorded and it will be archived on the Can Do MS website. So you're more than welcome to view the presentation again, or if you missed one of our upcoming webinars, you can find the archived version on our website as well. To ensure good sound quality with no background noise, all of the participants' phone lines are muted for tonight's presentation. So although your phone lines are muted, you still have the capability to submit questions to Dr. Schapiro, and we encourage questions at any time. Feel free to type them in using the chat feature that's located on the left of your computer screen. So you should see a box on the left-hand side of your screen that says chat. And to type in a question, all you do is start typing in the small box that says chat with the presenters. Dr. Schapiro will address as many questions as time will allow at the end of his presentation. And please remember that Dr. Schapiro cannot answer medical questions that are specific to you. So please try to keep the questions as broad and as common to the rest of the audience as you can. The Can Do MS webinar series is sponsored by an educational grant from Novartis Pharmaceutical Companies. And with that, I will turn it over to Dr. Schapiro. Randy, are you there? All right, we might be having just a few technical issues. Just give me 1 second.
Who can hear me? Can you hear me?
All right, we can hear you now.
Okay. Well,
great.
What button did you push? We need to remember that one.
Oh, we need to remember that one. That's exactly right. All right.
All right. Well, I'm Randy Schapiro, and I'm delighted to talk to you in this first webinar series for the Can Do Multiple Sclerosis programs. This is a very special group of people that belong to Can Do Multiple Sclerosis, and you're among that special group, so I'm really happy to be talking to you. I need to disclose to you that I am a consultant and a speaker for Accorda, EMD Serono, Pfizer, Questcor, and literally anybody else who wants me to talk for them about multiple sclerosis. I've done this my whole career, and my whole career is quite long, and I'm delighted to speak for them and anybody else that is involved. Tonight's topic is about emerging therapies, and I want to emphasize to you that research is important, and I'm not really a researcher. I've done more clinical research than most researchers have, but I see myself as a clinician, and so I come at this a little bit differently than a researcher might. Research actually comes from the Middle French, and it means to investigate thoroughly. And interestingly enough, Wikipedia says that it is an active, diligent, systemic process of inquiry aimed at discovering, interpreting, and most importantly, revising facts. And so what we're trying to do is get new knowledge by doing new research to discover new ways to help people, and in this case, help people with multiple sclerosis. Anybody that's heard me talk has heard me talk about managing multiple sclerosis, and I talk about what we'd all like to do is manage the disease itself. We'd like to change the course of the disease, and quite frankly, 25 years ago, we got the opportunity to potentially change the course of the disease when the immune modulating drugs began to become prominent. We have 7 FDA-approved immune modulating drugs, and so we can potentially change the course of the disease for many, many people. The backbone of managing multiple sclerosis is, however, and always has been, the symptom management of multiple sclerosis, a topic that I'm particularly interested in. And then we always have to remember that there's a person who has the disease as well. So managing MS is about person management as well as disease management and symptom management. And the tools that we have to use to manage multiple sclerosis include pharmacologic tools, rehabilitative tools, and psychological tools. Consequently, when we look at the areas of research in multiple sclerosis, they fall along those same patterns. So we have research in disease management, symptom management, person management, pharmacologic management, rehabilitative management, psychological management, and this breaks down into many other areas of research that you may not be thinking of. We all are interested in new treatments, and so we think of that. That's why it's called emerging therapies. But research in multiple sclerosis involves genetics. It involves the mode of action of the different treatments. It involves research into the immune system, cell biology, virology. It involves research into remyelination. It involves social and personal impacts of MS. It involves rehabilitation research, nursing research, economic research, symptomatic research. Quite frankly, there's no way in an hour that I can go over all of the areas of research that are so important in multiple sclerosis. And if you look at this, this is a multidisciplinary research effort. And that sort of parallels what CAN-DO MS is, a multidisciplinary approach to managing and dealing with multiple sclerosis. So I am not going to pretend that nursing research is any less important than new treatment research, because breakthroughs are being made in all of these, and they're all very important. But tonight we're talking about mostly emerging therapy research. But I need to give you some background to understand research in multiple sclerosis, because it's a complex topic, and it's complex to understand the research studies. We are in the era of exploding knowledge. We've been in this era of exploding knowledge now for almost 25 years. We have made more progress in the past 25 years than in centuries before that. And the reason for that is that we learned how to study multiple sclerosis. We learned that we had to do randomized, double-blind, placebo-controlled trials. I can't emphasize that enough. So these trials had to be randomized. That is, patients had to be placed in a random fashion. The patient themselves couldn't know whether they're on treatment or on placebo, because there's a tremendous desire to get better in studies. And so the placebo effect in multiple sclerosis is, and always has been, around 60%. So no matter what we do, if we give chicken soup, 60% of the time people will get better for a while. Just for a while. Consequently, we've seen some crazy therapies in multiple sclerosis. Therapies like bee stings, pregnant cow's milk, cobra venom, patches of various sorts that have caffeine on them, rocker clog shoes that were supposedly curative. Crazy therapies in which they always had a cadre of patients who said, I got cured, or I got so much better by this particular therapy. But they weren't done in a randomized, double-blind, placebo-controlled trial. So we learned how to do research in multiple sclerosis. Very, very important. And then the second thing is that we learned that we couldn't just study multiple sclerosis. We had to study populations of people who looked alike, who had multiple sclerosis. In the old days, we studied people who were bedridden next to people who were ambulatory. We studied them all together, and we failed on virtually every study. So we had to divide people up according to how they basically looked, the pattern of their disease. And so we had to separate people according to patterns of multiple sclerosis. And we recognize that 80% of people with MS began their journey with the disease in a fluctuating pattern. And you can see that pattern as fluctuations with attacks that we called relapses, followed by periods of calm, we called it remissions, exacerbating remitting, or relapsing remitting multiple sclerosis, 80%. And over half of them, if we left them all alone, over half of them along the way stopped having those attacks and slowly got worse. And so we just changed the name on those people. The disease didn't change. We changed the name. And we called that secondary progressive multiple sclerosis. 10% of people get worse from the get-go. We called that primary progressive MS. And 5% started out progressive and then began to relapse, so we called that progressive relapsing MS. It was never our intent, and I was involved in the making of these categories, it was never our intent to act like these were different diseases. It was just a pattern of the disease. We've sort of turned it around and acted like they're different diseases, but it's just a pattern of the disease. Now, interestingly enough, this all may be one disease, or maybe there are two diseases here, because relapsing remitting and secondary progressive, as you know, are 85% of people with MS are those two. The average age of onset is 30. It is a disease of women almost 4 to 1. It's a disease with lots of MRI activities and lots of spinal fluid activities, where primary progressive and progressive relapsing make up 15% of people with MS. The average age of onset is 50. It is 1 to 1 male to female. It's mostly a spinal cord progressive disease. It doesn't have a lot of MRI activity. It doesn't have a lot of spinal fluid activity. Maybe there are 2 different diseases there. And pathological studies have indicated that maybe there are 4 different diseases, but they're not labeled this way. They're labeled type 1, type 2, type 3, type 4, and they're pathologically distinct, not clinically necessarily distinct. So what we're looking at here is just simply a way to put people into studies who look somewhat similar so that we can actually get some progress. And we did get progress that way. If we look at the general community, we recognize that 55% of people out there talking on the phone here have relapsing remitting, 30% have secondary progressive. That makes up the 85% I was talking about, and then the 15% of progressive relapsing and primary progressive. Who performs MS research in today's world? Well, let me tell you, it's not just universities. It's mainly the pharmaceutical companies and biotech companies working with the universities. It's not-for-profit research institutions such as the National Institutes of Health. There are other non-affiliated groups and individuals. The National Multiple Sclerosis Society funds more research than any other single voluntary health organization looking at one disease. So a lot of different people are performing MS research. There are many ways to do research. The main type of study used to research today is the clinical trial, the randomized double-blind placebo-controlled trial. But there are other kinds of trials, such as population surveys, where you look at groups of people who have the disease and try to manage to coax out the differences between the groups. There are quality of life questionnaires. There's clear examination of brains and spinal cords and immune system cells. We call it tissue cell examination. There's a lot of laboratory research that's very basic, very difficult to understand. That's important. Now, for a drug to come to market, lots of things have to happen. And the first thing is the person who's doing the clinical trial does a phase 1 clinical trial. It's a safety trial. About 2/3 of the treatments that actually go through phase 1 studies progress and pass this phase. This is usually done in animals. You're trying to figure out, is this going to be safe or not? And then we do it in humans and say, is this going to be safe or not? And if it is, we move on to the phase 2 of the clinical trial. This is usually a small clinical trial, randomized, often blinded, focused on dose finding, focused on efficacy, and focused on safety. And you can see about 1/3 of the treatments pass this clinical trial. Then if we get that far, we move on to the big trial. That's called the phase 3 trial. That's the randomized double-blind trial that has been powered with enough patients that we can make some statements at the end of the trial whether the drug is efficacious or not. That's the difficult trial that brings the drug to the FDA. And a fair number of trials that get through this pass this trial. Then if it gets approved by the FDA, if the FDA agrees that those trials are done well, that the drug is unique and it should be on the market, then there are safety trials that continue on and are called phase 4 trials. This is why bringing a drug to market is so expensive. It has to go through so many phases. Each one is expensive in itself. Now I want to say a few words about neurologists. Neurologists are interesting people. They're very data-oriented people. They love data. They're anal-retentive people. They're very compulsive. They didn't get to be a neurologist by not being smart, so usually they're quite smart. And I have discovered that sometimes they're sarcastic. Can you believe that, a neurologist who's sarcastic? Sometimes I have a hard time understanding that. And, you know, what I've learned over the years is that occasionally neurologists are understandable, but most of the time they're not. And sometimes they're nice, and sometimes they're not so nice. And the reason I bring this up is because we're in an era of evidence-based medicine. And neurologists particularly love evidence-based medicine. I like evidence-based medicine. That is, that we practice based on studies that have given us proof of concept, proof of understanding, proof of evidence. But I am one who says that there is not one single drug that hasn't gotten better once it got in the hands of the practitioners, because the practitioners then begin to know how to use the drug. They may give it slightly differently. They may alter some of the things that were done in the studies. The studies bring the drug to market. The practice of medicine, which is experience-based rather than evidence-based, is what makes the drug successful. So it's not one or the other. It shouldn't be evidence-based medicine versus the practice of medicine. It should be, obviously, a merger of the two, and that's very important. And so in order to practice appropriately, we have to practice with what I have called garage logic. Now, I'd like to tell you that I invented that term. But Joe Soucheray, who's a radio commentator in the Twin Cities area where I come from originally, and continue to love, that the Twin Cities, Joe Soucheray has a radio program that he calls Garage Logic, in which he stresses that you use common sense thinking, and for many people that's best done in the garage. For some it's best done around the swimming pool, I suspect, but in Minnesota it's best done in the garage with the car off. And where there's less stresses, and you're not being bombarded with a cell phone and all kinds of questions and things of that nature. And then you recognize that data is not the end all. Sometimes data makes no sense. I'm going to give you examples of that. And experience becomes extremely meaningful. And so when you interpret studies, you need to use a bit of garage logic in those studies. MS studies are particularly difficult to interpret because our ability to measure disability in MS is particularly complicated. And what we all want to do is change disability. So how do we measure disability? Well, we have what do we call this? I'm blanking on a scale. We have a scale. I blanked on the term scale. We have a scale, which is called the Expanded Disability Status Scale of John Kurtzky. John is a good friend of mine. And he invented the scale in the 1950s and 60s, and it goes from 0, which you see on the bottom, which is normal, to 10, which is dead due to MS. I think there are probably several 10s listening in on the conversation today. No, not really. The fact of the matter is that it's rare to die from MS. You die with MS pretty much with a normal lifespan. So this goes from 0 to 10, normal to dead, but it's not a linear scale. You don't move up the scale in a straight fashion. So you can move from 0 to 4 and not look any different. Not look any different. That's 4 points. If you pee in your pants and you have a little bit of numbness, you're a 3.5. And so you'll look the same, but you'll be a 3.5. If you go, however, from 5 to 6, you go from being able to walk without an assistive device to requiring an assistive device to walk. If you go from 6 to 7, these are only 1-point changes. From 6 to 7, you go from being able to walk with an assistive device to not being able to walk at all. So you can move, on the bottom you can see, from 0 to 3 with very little change, 3 points. And you can move from 5 to 6, 1 point, and that's a major change. 6 to 7, 1 point, that's a major change. And then the change becomes less again in the higher areas. Consequently, when people say they change disability, you have to look at the study and say, well, were these 5 to 6s or were these 1 to 2s? It makes all the difference in the world, and yet they report a change in disability. That's what makes analysis so difficult, is you have to understand the research. So we're going to start talking about symptom research first. And I'm delighted to talk to you about a drug called 4-aminopyridine, or dalfampridine as it's called generically. I'm sorry that's not on the slide. Or Amperior as it's sold, as its trade name. And this is a potassium channel blocker that's been researched for a lot of years now, almost 25 years. It allows demyelinated nerves to conduct more efficiently. It was held back in research because of the possibility of seizures associated with this. this potassium channel blocker allows demyelinated nerves to conduct better. And so you see on the slide now an axon, the nerve, with covering called the myelin, the fatty material. The nerve impulse goes down this nerve by jumping along the nodes. However, when there's demyelination, as you see in this slide here, where the green axon in the middle of the slide to the right is a demyelinated axon. The myelin is red on either side of it, and you see the demyelination. That slows nerve conduction. And so what dalfampridine or Amperior does, 4-aminopyridine does, is it allows that electrical impulse to get through that demyelinated area pretty much intact. Now, if you look above, you'll see a green bulb. And that green bulb is an axon that's been broken. Once that axon is lost like that, then there is no nerve conduction. So Amperior was studied in a randomized, double-blind, placebo-controlled trials, actually 2 of them, and found to improve nerve conduction in about 33% of the patients who took it. And it wasn't dependent on the pattern of multiple sclerosis. So a lot of these people had progressive MS, and still they were able to walk better. The end point that was measured was walking ability. So it was approved about 2 months ago, actually, for walking ability. That's exciting news for people, actually, because if you are a responder, this medicine is available to you to help you walk better. The medicine itself doesn't know the difference between walking and arms and thinking and other things, but it was approved for walking because that was what was studied in the study. I want to talk a little bit about spasticity because we've made great advances there as well. Spasticity, the word comes from the Greek word to tug. It is velocity-dependent stiffness. That is, the faster you move the extremity, the stiffer it gets. And so those of you with stiffness and you try to move fast to get in the car know you get stiffer then. It's part of what we call in neurology the upper motor neuron syndrome. I won't go into that unless somebody really wants to. So what I want to say to you is that Botox, botulinum toxin, just a couple of months ago was approved for use in spasticity, for single muscle spasticity. We've been using it for years for this. The duration of action is every 3 to 4 months, and so what we do is inject the stiff muscle with Botox. It loosens up, the wrinkles go away. It's a beautiful sight to see. They're the prettiest muscles. I'm just kidding about that. But seriously, this is very effective at loosening single muscles when that's necessary to loosen. We've talked about over the years the use of marijuana in multiple sclerosis, and one of the uses of marijuana is for spasticity in multiple sclerosis. And it's appropriate to think about marijuana use in these things because there are cannabinoid marijuana receptors, if you will, in the central nervous system and in the immune system. Marinol has been tested, and smoked cannabis has been tested and shown to be of some value in spasticity, maybe not as much value as the drugs that we have available to us, and maybe with more side effects and more issues associated with it. And these are not approved for spasticity in the United States, but they're being studied for that. There is a drug in Canada, however, that is a cannabis derivative called Sativex, and that's been studied and is being studied in the United States as well. It's a spray of marijuana rather than a smoked marijuana, if you will, and it's being studied to reduce pain and sleep disturbances, but it has issues in that it seems to cause more cognitive problems and dry mouth. But this is being studied, so this is in research at the present time. Now, we're all worried about cognition. Cognition is an issue in 60% of people with multiple sclerosis. We've thought in the past it was due simply to the white matter pathways in the brain being damaged, but what we're learning is that multiple sclerosis, through research studies with tissue and studies of that nature, also can affect the gray matter, and that's giving us a better understanding of why cognition is involved. And so studies are going on in cognition. Ginkgo biloba was studied and actually did not work. It was studied to improve cognitive function, but it basically failed in that arena. Some people felt their attention span was improved, but that wasn't the end point being studied. Aricept has been studied and found to be of value. That's a drug for Alzheimer's disease in a small number of people who have cognitive problems in MS, and so it isn't really approved for that, but it has been studied. Provigil was studied in an Evidencebased study and seemed to improve cognitive function in a small study compared to Evidencebased alone. Memantine, which is another Alzheimer's drug, did not seem to improve cognitive function, but people are doing research in cognitive function. People are doing research into pain. Lyrica, pregabalin, was studied versus an antidepressant Paxil, randomized double-blind, the two active ingredients here rather than placebo, and clearly it seemed to improve MS pain. Gabapentin we have used for years. It is a relative of pregabalin, and it has improved MS pain, and so we're studying pain in multiple sclerosis. And there is a peculiar syndrome that is more common than we really realize. It's called PBA, or pseudobulbar affect, in which people cry inappropriately or laugh inappropriately, and there are studies showing that a new drug that is a combination of two old drugs, dextromethorphan is cough medicine, and quinidine is a cardiac medicine for arrhythmias. When these are combined in specific dosages, they do antagonize certain receptors in the nervous system and suppress this pseudobulbar affect. So this can be an important breakthrough. Now, before we get into talking about the new drugs that are available, or that are being studied to become available, you need to know something about the immune system to understand how these drugs work and their risks. And so I'm going to spend just a few moments and talk about the immune system, which is located all over the body. It's located in the tonsils and in the adenoids, in the lymph nodes, in the thymus, which sits over the heart. It's located in the spleen. It's located in the gut. It's located in the bone marrow and in the appendix. It's located everywhere in the body except in the central nervous system. So for this immune system to get into the central nervous system to attack it, several things have to happen. And this diagram looks a little complicated, but I call your attention to the upper left corner where you see the word macrophage. And one of the things that has to happen is that an antigen, a foreign substance, something foreign, has to be presented to the immune system, and it's presented to the immune system by a cell which is called an antigen-presenting cell, and a macrophage is an example of that. So this macrophage presents this cell, presents this foreign substance to the immune system. It then recognizes it as foreign, and the Th1 cell that you see there now carries a stamp that says, I'm going to get something that looks like this. In fact, it says, I want to get this foreign substance. So if it's a virus, it wants to get that virus. Sometimes it gets sort of misappropriated, and that Th1 cell gets programmed to attack something that reminds itself of the foreign substance but isn't the foreign substance itself. So that Th1 cell gets into the blood vessel, and you see it in the blood vessel. Here it is in the blood vessel. For that Th1 cell to get into the nervous system to attack the nervous system, it has to get through the wall of the blood vessel. To get through the wall of the blood vessel, it crawls along the wall, and then it gets pulled into the wall of the blood vessel by adhesion molecules. It gets pulled in, and you see it being pulled into the wall of the blood vessel. Now, the reason I'm going through this in such details, you see that integrin and VCAM there, is because we learned this and we said, well, maybe we can stop this from happening. We'll develop a substance, an antibody, if you will, that's designed to stop this from happening, a special monoclonal antibody. And we'll call that antigrin. And so that was discovered and developed, and it worked, and it became what is now known as natalizumab or Tysabri. So we see how that works to do that. I'm going to skip through that cell there. So we got natalizumab Tysabri. In a randomized double-blind placebo-controlled trial, this was the first drug that was specifically designed to treat multiple sclerosis. However, what we have learned, of course, is that sometimes you need some of these cells to get into the nervous system to protect it, and there are risks to this, and by taking this, some people will develop a viral disease that is only seen in immune-suppressed patients called progressive multifocal leukoencephalopathy, which is terribly disabling, if not lethal. And so we have to always recognize in new drugs that there is a risk versus benefit, and we have to understand the risk versus the benefit. And I'm not here tonight to talk about when we use this drug or that drug or why or how, but I want this to be an example of understanding that there's always a risk in taking new medication. And so it's not just because it's new that we want to jump at it. But there are lots of studies going on. There are studies looking at vaccines that are designed to alter the immune response to various substances. BHT 3009 is one that is looking at antibody response to myelin basic protein. It promotes a specific immune response. Lipitor, the statins are being studied because they promote specific immune responses. If we could knock out the immune system and replace it with an immune system that is not so damaged and not so promoting, not so active, we could slow MS down. So we can do that with cyclophosphamide. Then we can take bone marrow stem cells from the person before we give them the cyclophosphamide, and we can clean them up and give them back to the person, and hopefully they will remake the immune system and slow the disease down. This slide says 11 patients. It's far more than that now, far, far more than that. And it has a real potential with real risks associated with it. Now, I want to spend a little bit more time on fingolimod, FTY-720, because it's highly likely that this will be the first oral medication that comes to market. It was just approved by a panel of the FDA to go to the FDA, and it will in a few weeks. And the FDA usually accepts what the panel says. And so this will be the first oral medicine that is available to treat multiple sclerosis, and it's a unique medicine. It's what's called a sphingosine 1-phosphate receptor binder, which means that the lymphocytes that are the ones that are involved in making multiple sclerosis more active get caught up in the lymph nodes before they get to the nervous system and are not allowed out. They're like put into prison and kept in there, and so they don't cause the damage. And in several randomized, double-blind, placebo-controlled trials, fingolimod showed that it was able to cut the relapse rate down, slow the disability progression, and change the MRI to make it less active than placebo, and then some active agents. This is important, but it's, as I say, a new agent, and the risk versus benefit has to be understood. We don't entirely know the risk because 2 years wasn't enough to tell us with natalizumab. So this we'll learn in the next few years the real risk, but we worry about such things as infections, such things as tumors. Now, there wasn't a big index of that, just a little, but nonetheless, we have to be concerned. But this is exciting news, the first oral agent that potentially might be coming down the pipe. There are other oral agents, though, that are being studied. Fumaric acid is a drug that's been used in psoriasis. It's called BG12, and it changes the immune response and makes it more, shall we say, preventative. And because it's been used in psoriasis, we have a safety profile. So we understand this is being studied in a randomized double-blind fashion. That's being studied by Biogen. Teva is studying a drug called laquinimod, and it's a cousin of a drug that we studied years ago called linamide. It has an immune modulatory picture. It's not supposed to have the side effects of the drug that we studied before, which didn't make it through phase 3 studies because of it had too many side effects. This is being studied now in phase 3 studies, and we'll see what the results are. Exciting studies. Campath, which is alemtuzumab, is another monoclonal antibody which targets a particular antigen, CD52, which is on B cells and T cells, on lymphocytes. And it, in studies, has shown to be very effective, marketed by a couple of companies, one of them Bayer, or being studied by them, I should say. This is being used in cancer chemotherapy. This treatment is very effective but has a ton of side effects associated with it that we have to be very concerned about, including malignant thyroid disease and some platelet disorders. So it's exciting, but there are issues associated with that. CellCept is being studied as well. Not as actively, but it is available and being studied. Oral cladribine is very actively being studied by EMD Serono. This is a potent immune suppressant agent that reduces lymphocytes and has study data that is well known to us showing that it is quite effective in reducing relapses, slowing progression, decreasing MRI activity. The side effect profile it was not terrible in the studies, but is one of those that raises our eyebrows. We have to be concerned about infections. We have to be concerned about tumors. We have to be concerned about continuing to have the immune system reduced. But this is a drug that's only taken a couple times a year. FTY 720, by the way, is a daily pill. Tovaxin is a T-cell vaccination, which is unique and interesting and being studied in many places. Terflutamide is another agent that is being studied that decreases the synthesis of pyrimidine in T cells. All of these things are unique and interesting to study. Daclizumab is another monoclonal antibody that reduces a particular cytokine that we think is involved in multiple sclerosis. So this is a subcutaneous injection that's being studied. Rituximab is a drug that's used in rheumatoid arthritis and certain cancer therapies. It is a B-cell drug that has been shown in a number of studies to decrease attack rate, decrease the progression of relapsing multiple sclerosis, and decrease MRI activity. It was studied in primary progressive MS and didn't show a good enough effect to move on, but it did show an effect in certain people, so that might be a clue that we need to study certain people with rituximab. Copaxone has been studied in a number of different ways to look at the future of that. Beta-seron was studied in a double-dose fashion, and unfortunately it didn't really work out very well. There's a new formulation of Rebif that's being used around the world and is being studied in the United States. And then we see vitamin D being studied now very thoroughly. Vitamin D, an interesting vitamin which follows the epidemiology of MS in that people in the northern parts have less vitamin D than in the southern parts, and they have more MS. Very interesting vitamin, very interesting study. Unfortunately, every disease wants to lay claim to vitamin D, and when I see that pattern, I begin to doubt what's really important. But we'll see. This is exciting times. Now, I want to spend a few minutes about a treatment that I think is not appropriate and inappropriate and is being hyped and totally wrong, and I can get into big trouble for doing this because the can-do multiple sclerosis people, bless their soul, want to be neutral, but I'm not known for being neutral. I've seen too many bogus treatments come around, and to me, chronic cerebrospinal venous insufficiency meets none of the criteria for a valid treatment in multiple sclerosis. It does not pass garage logic. It was born about from the fact that a vascular surgeon in Italy, Dr. Zamboni, his wife apparently has multiple sclerosis, and for some reason he studied the veins in her neck and found that they were narrowed. This vascular surgeon, to a hammer, everything looks like a nail. To a surgeon, everything looks like it's surgical. He decided to treat her surgically by dilating those veins, and lo and behold, in a non-randomized, non-double-blind, non-placebo type effect, she felt better. 60% of people will feel better. He then looked for this narrowing of veins in 100 people with MS and found 100% of them had this narrowing. Dr. Zavadnov is an MRI expert at the University of Buffalo, and he looked at 100 people with MS and found 60 of them had this narrowing, but 30-some-odd people who didn't have MS had this narrowing. This absolutely makes no sense because if you know anything about veins, they look different in everybody. Arteries look the same, veins look different. This does not fit the epidemiology. Do more women have this? Do more northerners have this? This does not make any sense to me. And so I find it very unfortunate that this is making news and that there's a lot of money going on into spending into proving that this isn't going to work. So I put myself out there and say, this isn't going to work. We don't need to spend the money on it. But if you want to follow your nose, fine. But you're not going to follow it with my acceptance of this. And so the National MS Society is being very kind in sponsoring research. They sponsored cobra venom research, too. That didn't work either. But research in genetics is showing us a fair amount of success. We're learning that there is an area in chromosome 6 that gives increased susceptibility to MS. We knew that, but there are linkages involving 3, 5, and 19 that in a minority of individuals will tell us something about their MS. And we're going to learn more about this because this is not a hereditary disease, but clearly you can see there from what's written, and I don't want to run through it because we're going to run out of time here, that there is a genetic aspect to multiple sclerosis. That is exciting research. Research into stem cells, I think, is exciting as well. And I put this picture in to show you that there are different kinds of stem cells. And embryonic stem cells are what are called pluripotent. That is, we can make them into neurons, we can make them into skin cells, we can make them into muscles, we can make them into blood cells, where adult stem cells are already programmed to go to the way they're going to be. I wanted to show you a picture of an embryo because most people mix up embryos and fetuses. An embryo is not a fetus. It's just a bunch of cells that are there that look like cells. And these cells come from fertility clinics in which they're going to be thrown away because they're of no use. But we can take these cells and do research, and this may be the first way of developing a way to put back myelin into the nervous system, put back axons into the nervous system. We can do it in animals. We have to do it in people. So this is being studied. Now maybe we can make these pluripotent cells from other types of stem cells. That's being studied as well. But right now, embryonic stem cells are our best bet. We've had studies in virology. Every decade, we thought we had the virus. We thought it was the measles virus in the 70s, the herpes virus in the 80s, a virus that looked like an AIDS virus but a different retrovirus in the 90s. We thought it was the herpes 6 virus. We thought it was the chlamydia virus or bacteria. But now most people are wondering about the EB virus, which is present a lot in people with MS. It's the mononucleosis virus. We're looking at that virus very closely. And we're looking at complementary treatments and studies as well. I don't like the word alternative because this is not alternative. This is to do along with your studies. We studied prayer in a randomized double-blind placebo-controlled trial. Unfortunately, it didn't work at our Fairview Center years ago. But omega acids are being studied, for example. Acupuncture is being studied. So I want to emphasize that we've come a long way with research of many types, interdisciplinary, multidisciplinary research. There are a lot of drugs that I ran through very rapidly to give you an example of how things look. They look bright, but, you know, the present isn't so bad either. We have come a long way, baby. We have a lot more to go. We want to thank Novartis for sponsoring this series. And you see the upcoming webinar discussions here, and I now am available for questions. And I think I am to take these questions, so I will just sort of go through these here. In secondary progressive MS stage, we can expect some degree of improvement of walking with Amperior if the person is not able to currently walk without assistance. Let me read that again. In secondary progressive stage, can we expect some degree of improvement of walking with Amperior if the person is not able to currently walk without assistance? Well, you never know. You know, this is a nerve drug. The question is not the secondary progressive aspect of it. The question is how much of the disease in that person is due to axonal loss versus how much of it is simply due to demyelination. And so the only way to tell is to try it and find out. And if the person is one of the 35% or so that are responders, they will respond. And if they're not, then you don't continue the drug. How long do you try it? You'll know likely after a few days, but I would probably try it for a month, and then if it worked, I'd continue it. If it didn't work, I would give up on it. I read sometimes that an oral disease-modifying drug with less side effects would be available to the public in 2010. Is that true? As I indicated to you, I don't know how many drugs may be available in 2010, but I believe that fingolimod, FTY-720, will be available. I hope it will be. It hasn't been fully approved, but we don't know entirely the side effect profile of it. I can't tell you it has less side effects. And so this is going to be a risk versus benefit situation. So people have to be carefully selected to make that decision. Just because it's oral doesn't mean that it's simple. Just because it's oral doesn't mean it's simple or safe. So we have to be very careful about that and listen to your doctor and listen to the researchers and try to get a feel for this so that you are well educated. Next question, who is doing stem cell transplants in the United States? A lot of people are doing them, but Northwestern University and the University of Washington are two major centers doing stem cell transplants that are studying them very carefully. The next question is beta seron no longer shown to be effective? That's absolutely not true. I don't know where that came from. Beta seron continues to be effective for those who are affected by it. In other words, not everybody responds to beta seron or any of the other immune modulating drugs. We try to find the right drug for the right person at the right time. Beta seron has not been shown to not be effective, that double negative. It is effective. What was shown was that double-dose beta seron in the study, double-dose beta seron, did not do any differently than single-dose beta seron. But to be perfectly honest, it was a terrible study. And so I truly believe that the higher the dose in people who haven't responded to lower dose may still respond. But that's not too many for you to go through. I don't know what that means, but I'm just going ahead. Also, what are your thoughts on chiropractic therapy being an alternative therapy? I don't like alternative therapies. I don't like them. I just don't like them. Alternative means you're doing it instead of the studies that have double-blind, randomized, placebo-controlled trials. But chiropractic doesn't have to be an alternative therapy. It can be a complementary therapy. That is, it can be done in association with the real drugs. And then I have nothing against it. It can help spasticity. It can help people's well-being. But don't make me believe that the chiropractic manipulation is going to change that immune system and make MS improved over other truly studied therapies. I had understood that embryonic stem cells could promote tumor growth. Absolutely true. It can promote tumor growth. That's why we need a lot more research. Embryonic stem cells are at the beginning of the research pattern. If we just go wild with them, there are a lot of side effects that can occur, and tumor growth is one of them. So we need to study them. I'm going to scroll up and get some more questions here, I hope. In Dr. Schapiro's opinion, what one emerging therapy is he most hopeful about? I'm most hopeful about the ones that work, so I'm not going to pick one that I'm most hopeful about. We need to have them to use them. So far, FTY is the one that looks like it's coming through the finish line first, but when the others come through, I hope that we'll be able to choose the right drug for the right person at the right time, and that will be important. Let me see here. What are they doing to me? You're moving things around. Okay. Here. There are more questions if you scroll up. I'm trying to do this. How long will it take for stem cells to be a viable treatment? I don't know. We have to do the research to find out. And we're just now gotten permission, really, in the United States to do some of these research. Why would eating cause MS symptoms? Well, it typically doesn't. So that's an individual person who is eating would cause irritation. Sometimes they may be allergic to a particular food that may cause the symptoms, but mostly it's likely that blood flow went into the stomach and took it away from somewhere else, and they had a transient change in symptoms. But that's not typical. That's not a typical thing. Okay, now where am I? I'm down here. Can one take Amperior as needed once a day? It's important to take Amperior no more frequently than every 12 hours. That's one tablet twice a day, but not together. It has to be separated by 12 hours. It's a sustained release medicine. If you could take it once a day and get away with it, that would be all right. That's not the approved fashion. But you can't take it 3 times a day, and you can't take 2 together, because that will get you toxic, and the likelihood of seizures will become more prominent. So you can take it once a day if you wanted to, but the treatment is 1 twice a day. Will a person see immediate results from Amperior, or might symptoms improve over time? Because this is a nerve-conducting medicine, I expect immediate results. Sometimes there are symptoms that improve over time. Then I don't know whether that's due to the drug or just over time. So I expect cause and effect here with this drug. You take the medicine and you feel improvement right away, maybe even the first day, but certainly the first week, and clearly in the first month. And if it's not there, there have been people who got improvement later in the studies, but not many. So I wouldn't push that. The next question is, thanks for questions so far. I'll address this question. Can you take Amperior and Marinol at the same time? You should not take Amperior and Marinol at the same time. We don't know the interactions of those 2 types of drugs. They're very active. They're active in the CNS. I would not recommend. They have not been studied together. I would not recommend doing that at the same time. Can you post the telephone number? No, that's a no. Are the slides available for printout? I would guess somebody can make them available. This seminar can be retrieved at a later time. I'm told that it's being stored somewhere, and you'll hear about that. So I'm going up to the top again. Okay. So where are we here? I have had relapsing multiple sclerosis for 13 years and think I now have secondary progressive. How might this transition impact my medication? See, I don't like this classification to be used in this manner. This was not the way it was meant to be used. It was meant to be used for research studies. So secondary progressive, relapsing remitting, to me, they're all multiple sclerosis. The idea is that you want a medication to slow the progression of the disease and forget that terminology. Are some disease-modifying medications used for relapsing? They were studied in relapsing remitting MS as opposed to secondary progressive. But there are patients with secondary progressive MS who respond to disease-modifying treatments. Now, you could say that's off-label because they weren't approved for that, but that may be off-label. We still do that type of thing, even because we're trying to slow the disease down. Now, if you have progressive disease and you take a disease-modifying treatment and the disease is not slowed down after you've taken it for 6 months to a year, then you don't continue it. That makes sense to me. Is there a way that we, the consumer, can help a drug move through phase 3? I personally don't want you, the consumers, trying to make these drugs move through phase 3 studies. That has to be done in a scientific manner, not being pressured by the press, not being pressured by politics, being pressured by trying to get honest answers to honest questions so that we don't get crazy treatments like I'm talking about earlier. We want to have science backing this, not pressure, and unfortunately that's what happens. Where are we here? Any idea how long will it take? No, I mentioned, what am I doing? Going up to the top again? I'm starting Amperior Thursday. How long will it take to see if I can lift my leg and foot without assistance? Well, I don't know that you need to walk without assistance. That's not the goal. The goal isn't to walk without assistance. The goal is to walk better. It may be that you continue to require assistance, but the idea is to walk better. And you should know personally, as I said, in a couple days, but it may take a week. I'd give it a month. But it's not the idea isn't to walk without assistance. The idea is to walk better.
All right, Randy, it's been about an hour.
That's
do you
the way
have
I see
any?
it too.
Perfect. Do you have any closing remarks?
Well, I tried to run through these questions quickly to get as many as I could in there. I hope that people caught the important points of it. But I hope what you can sense from what I'm talking about in very rapid fashion is that I'm excited about what's going on with emerging therapies. I'm excited about the research that's being done in multiple sclerosis. And I hope that you can share my excitement as you see this growing over time. You know, I've been doing this for over 35 years. If I would have given this seminar 30 years ago, it would have been probably about 10 minutes in duration, and I could have talked like I'm talking now, very slowly. We have lots of exciting things going on. So I hope you'll tune in to the upcoming webinar discussions, Spirituality, August 10th, Exercise and MS, 14th, Bladder Issues, Healthy Eating and Nutrition, Relationships and Communication, and I hope you've enjoyed what I've had to say, and I thank you all very much.
Yeah, and just to reiterate, that was a great presentation, and thank you, Dr. Schapiro, and a big thanks to all the participants who joined us for the first webinar of the series. We had a great turnout, and we're really excited about the upcoming webinars. As soon as this webinar is over, though, you'll see a survey that appears on your screen. So we're just asking you to just take a couple of moments to complete the brief survey. Your feedback and input is important to us. So thanks again, and have a great night.
Thank you. Please stand by.